Welcome to the second video. This is pharmacology and local anesthetics. First, let's discuss what is pharmacology. So this is the study of drugs and their effects on physiological systems. A very important definition. It is divided into two main branches, pharmacodynamics and pharmacokinetics. Pharmacokinetics gives us the nightmares. This was asked in the mock. So first one we'll do pharmacodynamics. So this describes what the drug does to the body. Dynamics, drug. Dynamics, drug. What the drug does to the body. So if they ask pharmacodynamics, it describes what the drug does to the body, and it involves interactions with cellular components. I think that's worth 1 point. And you must be able to discuss the receptors. So what are those? Those are proteins on the cell surface that can be activated by an agonist. So define what an agonist is, or blocked by an antagonist. So agonist, it activates it or helps the main drug serving as an agonist or an ally, or backed or blocked by an antagonist. This is the contrabida, or the one hindering your plans, the antagonist. Next is the ion channels. So these are pores that allow specific ions to pass through the cell membrane. This creates electrical potentials, or your depolarization and repolarization, those ion channels. Your sodium, your potassium channels, just to give a couple of examples. So next are the enzymes, or the biological catalysts that can be inhibited or activated by drugs. So in a nutshell, that's pharmacodynamics, what the drug does to the body. And next is pharmacokinetics. So this describes what the body does to the drug. The body does to the drug. If you remember your physics class, your kinetic energy. So it's when you move. So what the body. So you use your body when you're moving. So what the body does to the drug. Pharmacodynamics, what the drug. Double D's. Dynamics, drug does to the body, and kinetics, what the body does to the drug. And it's summarized by a simple acronym ADME, 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 and subscribe to me. First is absorption. So absorption, the drug's movement from administration site to the systemic circulation. And we can discuss this more in detail. Just comment down below if you want this more in detail, because it involves the liver, the first pass effect, and many more. Next is distribution, or the delivery of the drug to different body tissues and compartments. So that's your distribution. These are your pushers. Next is metabolism. So this is the chemical alteration of the drug, primarily in the liver, to prepare it for excretion. And the last one is excretion, removal of the drug, and its metabolites from the body, most commonly via the kidneys. Just most commonly, but that's not the only way. So again, if you want more in detail, just comment in the comment section, and then we'll make a video out of that. Next is a simple neuron physiology and pain pathways. So this is understanding how neurons transmit signals. And this is a key understanding on how local anesthetics work, because we're discussing pharmacology and local anesthetics. Next is, so first, the neuron. It consists of dendrites. If you're not familiar with the anatomy of the neuron, just review it quickly. So this is a cell body. It has a cell body, an axon, and axon terminals. Some axons are covered by a myelin sheath, so not everything, not all the neurons, but just not all the axons. I mean, so some axons are covered by a myelin sheath for faster signal transmission, or which we call saltatory conduction, where it jumps. So the thinner the myelin sheath, or if it's non-existent, it will not it will travel, and if there's a myelin sheath, it will jump, 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 jump. But if there's no myelin sheath, there it will travel on a straight line, and it won't jump. Next is action potential. So this is one of the more important concepts in the pain signal. So a nerve impulse generated when a stimulus causes voltage gated sodium channels. So for some reason I cannot code this properly, so it comes out like this. I just want to put Na plus, Na plus, but it gives the dollar sign. So voltage gated sodium channels to open, allowing an influx of sodium ions to rush into the cell, and this will cause depolarization. So this is highlighted in bold because that's one important concept in local anesthetics: depolarization. It's when sodium ions rush into the cell, and the membrane then returns to its negative resting state, which is repolarization. And this happens when um, repolarization happens when the potassium channels open, because there's a sodium potassium pump, which we can discuss more in detail. But there is a sodium potassium pump, and then the potassium runs or rushes out, and the cell again goes to a more negative state, or returns to its negative resting state, which is repolarization. Then pain fibers. Pain fibers. So pain signals are transmitted by specialized nerve fibers. They are A delta and C fibers. So for this reason, this cannot be coded properly again for some reason. So A delta fibers are myelinated versus unmyelinated for C fibers. So A, it transmits a sharp and localized pain. So A is targeted. So A delta. So that's targeted. And C fibers are unmyelinated, and they transmit slow and poorly localized pain. That's just their main difference in a nutshell. So the next one, so I hope that's clear. And next one is local anesthetics. So what's its mechanism of action? So local anesthetics, or LAs, they prevent pain by reversibly blocking nerve impulse conduction. So they diffuse across the nerve membrane and bind to block voltage-gated sodium channels from the inside. So that's a keyword, from the inside. So it will give you an idea that they must travel going inside. So this prevents depolarization and stops the action potential from being generated. So the action potential here, which is the depolarization, it gets blocked by your local anesthetics, so you don't feel pain. This prevents depolarization and stops the action potential from being generated. And we have two classifications, esters and amides, which we use in practice. So its features, we have just three: metabolism, allergy potential, and examples. So metabolism, we have esters and amides. So esters, they rapidly gets used in plasma, or metabolized. They gets rapidly metabolized in plasma by cholinesterase. So that's one key. So cholinesterase. And And with this concept, you can connect it here. In its allergy potential, it will be higher due to PABA metabolite or the para-aminobenzoic acid. It will be higher. Now, why is this? Because it gets rapidly metabolized in plasma by the cholinesterase. So if it gets rapidly metabolized, it gets converted to this metabolite, which is an allergen, the PABA. So next is your amide. So it gets slowly metabolized in the liver. So slowly metabolized, and its allergy potential, it's extremely, extremely rare. Your example is procaine and tetracaine for your esters, and for amides, it's lidocaine and bupivacaine. So clinical application, your routes of administration. Next is adjuncts. So you might see epinephrine or adrenaline, depending on who made the local anesthetic. So they add epinephrine. So why is this? So this is a vasoconstrictor, and it's added to LAs to prolong their duration of action and reduce the risk of systemic toxicity. And this is by delaying systemic uptake out of it. Next will be the local anesthetic systemic toxicity, or commonly known as LAST. This is a rare but life-threatening complication from high systemic concentrations of local anesthetic. So this is a uh, very important skill that we need to have. It's to identify symptoms of LAST. So key signs of LAST. So CNS early, CNS, there's a late, and CVS or cardiovascular. So CNS early will be circumoral numbness, metallic taste, tinnitus, and disorientation. So that's one thing, especially we're the ones injecting or giving this local anesthetic. So early on, there will be circumoral numbness, metallic taste, tinnitus, or the ringing of the ear, or disorientation. Next, it will go to a late CNS state, which can be induced by seizures, coma. But the first one we will see is in cardiovascular system is a high or excitatory, which is your hypertension and tachycardia initially, followed by profound hypotension and bradycardia, and and also very the very thing we don't want is a cardiac arrest, and it has a potential to give cardiac arrest. So first one we will see is the CVS, and then CNS. Um, that's usually how it's given. Next is management of LAST from the AAGBI, or Anesthetic Association of Anesthetists of Great Britain and Ireland. First and foremost, so of course you're injecting the LA or the local anesthetic. You stop injecting the local anesthetic and call for help immediately. If you're in an environment, all clinical environments have this red button, so you pull the red button or press the red buzzer immediately. You manage the airway, administer 100% of oxygen. Of course, use your clinical judgment, especially if a patient doesn't need, but you manage the airway because it will be fast. Next is control seizures with benzodiazepines. So just check your local guidelines. And next is administer 20% of intravenous lipid emulsion, or intralipid, for severe cardiovascular toxicity or cardiac arrest. Now, this is the cornerstone of treatment, working by the lipid sink theory. So what it does, the intralipid creates like a lipid sink wherein the local anesthetic goes to it, so it won't go to your brain, the CNS, and other major organs. Next is follow-up. This will be a transfer to a suitable clinical area for close monitoring.